Hello.
Hello, doctor. Can you hear me?
Yeah, I can hear you. Any madam?
Yes, yes.
Hello, madam.
Yes.
Can you see me?
Yes, yes. You are very visible. No problem.
And you can hear me as well, right?
Yes, I can
Okay,
see
fine.
you. I
Okay.
can hear you. No
Yeah.
issues.
Okay. Thank you.
Okay.
And to share the slide, I believe this is the present. Okay, that may be that. Okay, fine.
Yeah.
No problem. Okay. Yeah. I think Sachin sir has not joined still.
He'll join in 15 minutes, he said.
Okay. Probably he's in the hospital and he will be joining from the
Yeah.
hospital. Yeah. See,
Yeah.
I am at Trivandrum. I am on a weekend leave actually.
Okay. So maybe we can just for temporarily keep the video and audio out and
Yeah, sure. And the hope the videos will also play. I have some videos to show as well.
yes, maybe
Yeah,
we can
sure.
do a trial now.
Okay, fine. Okay. Thank you.
Hello, am I audible?
Yes, ma'am.
Yes.
Yes, yes, Shani, you're audible.
Okay, ma'am. So, good morning, one and all. Myself, Shivani Raju. I take this opportunity to cordially invite each and everyone to join here in this session for the webinar on deep brain stimulation organized by the Department of Physiology, M.O.S.C. Medical College, Korancheri. So, let us start off with a 1 minute silent prayer. So, good morning once again. I'm honored to introduce to you the speakers of today's session. We have with us Dr. Sachin Suresh Babu, MD, DNB, DM Neurology, Fellowships in Sleep Medicine and Epilepsy. I welcome you to the session, sir. We also have Dr. Sreeram Prasad, MD, DNB, Medicine and Neurology, DM Neurology, MNA/MS, Fellowships in Movement Disorders and Deep Brain Stimulation. I welcome you to the session, sir. We also have Dr. Krishnan Balagopal, MD, General Medicine, DM Neurology, who will be moderating the session. So it's a great pleasure to have you all with us. And without wasting much time, let me invite Dr. Anne Mathews, Professor at HOD, Department of Physiology, M.O.S.C. Medical College, for the welcome speech. Ma'am.
Thank you. Thank you, Shivani. Thank you for the introduction. And it's my pleasure to welcome you all. So, for the welcome address, first of all, good morning to all. Good morning to one and all. Welcome to the third session of the webinar series conducted by the Department of Physiology, M.O.S.C. Medical College, Korancheri. I, Dr. Anne Verghese, on behalf of my department, extend a warm welcome to all who have joined us today on this platform. This webinar is considered as an academic requirement for part fulfillment of simulated virtual learning and research modules of the latest CBME syllabus revision for MBBS students as stipulated by the NMC. It's my proud privilege to welcome our respected Dean, Dr. K.K. Divakar, and our distinguished speakers, Dr. Sachin Suresh Babu and Dr. Sreeram Prasad. Hearty welcome to our moderator for the day, Dr. Krishnan Balagopal. It's a pleasure having you all here. Extending a warm welcome to Dr. Sachin Suresh Babu, HOD and Senior Consultant Neurology, Director Research and Innovation Center for Neurosciences, Mitra Hospital, Kozhikode. It's a privilege to have an academic prodigy, dedicated researcher, and an accomplished neurologist, Dr. Sachin in our midst, who will be retuning the neural networks for us in his exemplary style. Hearty welcome to Dr. Sreeram Prasad, consultant neurologist and movement disorder specialist, Rajgiri Hospital, Kochi, who is one of the most well-trained and accomplished movement disorder specialists in Kerala, with exclusive fellowship in deep brain stimulation. He will take us through the role of deep brain stimulation in Parkinsonism. Welcome, Dr. Sachin, and welcome, Dr. Sreeram. Hearty welcome to Dr. Krishnan Balagopal, consultant neurologist, dedicated researcher, and a distinguished member of our MMM family, who will be moderating today's sessions. A thorough gentleman, it's a great pleasure to have Dr. Krishnan here to provide valuable insights regarding DBS. I extend a very cordial and hearty welcome to all distinguished faculties across the state who have joined us today and are encouraging us with your presence. A warmest welcome to all the dear students for whom this webinar is primarily meant for. I'm eagerly looking forward to all the exciting and enlightening sessions ahead, welcoming one and all to the webinar again. Thank you.
Thank you, ma'am. Now we have Dr. Nina Mathews, Assistant Professor, Department of Physiology, with bird's eye view to what brain stimulation is.
So, good morning, everyone. I'm Dr. Nina Mathews, Assistant Professor in Physiology at M.O.S.C Medical College. So, I'll be giving a brief overview regarding deep brain stimulation. So, at the outset of increasing neurological conditions, deep brain stimulation is a surgical procedure that has evolved over the years in the effective management of various movement disorders. So, what exactly is deep brain stimulation? So, deep brain stimulation, it is an electrosurgical procedure in which electrodes are implanted adjacent to the specific deep brain structures. So, these electrodes or leads, they will be delivering electrical impulses to the precise brain locations, which will be controlling the abnormal brain activity, which can lead to manifestations like gait abnormalities, motor disturbances, tremors, etc. Now, discharge of these electrical impulses by these leads or electrodes, they are in turn controlled by a pacemaker-like device. We call it as neurostimulator or a pulse generator that is placed under the skin in the upper part of the chest, that is just below the collarbone. So this is just a nutshell regarding what deep brain stimulation is. Now coming to the important components of the deep brain stimulation. It has three major components. That is, one is the DBS leads or the electrodes. Then there is an extension wire, and the last component being neurostimulator. So this DBS leads, they are thin insulated coil wires ending in tiny electrodes, which will be inserted through the skull via an opening, and it will be implanted or placed in the brain tissue. And it is these leads or the electrodes which will be delivering electrical stimulus to the targeted sites. Now next is an extension wire, which is again an insulated wire, which will be connecting this leads to the pacemaker-like device. We call it as the neurostimulator. So this extension wire is also an insulated wire that is passing beneath the skin all the way down from the head, neck, shoulder, connecting these leads to the neurostimulator. And finally, there is this neurostimulator, which is a pacemaker-like device, or also known as pulse generator, that is placed beneath the skin in the upper part of the chest, just beneath the collarbone. Now, this pacemaker-like device, it is having an inbuilt battery and a circuitry that will be generating the electrical signals, which will be ultimately delivered by the leads to the specific target sites. Now, this is a diagram showing the important components like the leads with the electrodes, and this is the extension wire all the way down, and this is the implantable pulse generator or the neurostimulator. Now, the clinicians or the practitioners, they can adjust the settings of this neurostimulator. You call it as programming of this pulse generator. That is setting the various stimulation parameters. That is the appropriate pulse frequency, amplitude, pulse width, etc. They can be set by this clinicians or practitioners externally via a handheld device, so that maximum benefit with least side effects is obtained. So these are the important components of deep brain stimulation. Now moving to the indications of DBS or deep brain stimulation, or what are the common conditions that are often treated using deep brain stimulation, and they are mainly movement disorders, and one of the most important and common condition being Parkinson's disease, which has shown significant results after the treatment of after the treatment with deep brain stimulation. Then other conditions include neurological conditions like dystonia, which is characterized by involuntary twisting movements of the body parts. Initially, that occurs during voluntary movements. Then there is essential tremor characterized by regular involuntary movements of the body parts while performing an action, not during rest, unlike in Parkinson's disease. Then other conditions like medication-resistant epilepsies, obsessive compulsive disorders, or other conditions that are also treated using deep brain stimulation. So one of the important and common neurological condition that is being treated using deep brain stimulation is Parkinson's disease. So a few words regarding Parkinson's disease and its pathophysiology. So this Parkinson's disease, it was first described by James Parkinson in 1870, and it's a progressive neurological disorder that is caused due to the destruction or degeneration of the dopaminergic neurons in the basal ganglia. So this basal ganglia, it is a subcortical mass of, or it's a subcortical mass of nuclei that is situated at the base of the brain, and degeneration of the dopaminergic neurons in this basal ganglia nuclei, as shown in this diagram. You call it as the nigrostriatal neurons, the dopaminergic neurons. So the massive destruction or degeneration of this nigrostriatal dopaminergic neurons is what is responsible for the major manifestations of Parkinson's disease. So what are the important clinical features or manifestations? And majority of them are motor manifestations like resting tremor that is occurring during the resting state. Then bradykinesia, which is slowness of movement or difficulty in initiating movements. Then rigidity, stiffness or increased resistance that is offered against passive movements by the limbs. Then postural instability or loss of balance. Then other features include stooped posture, shuffling gait, then difficulty with fine coordinated movements, and even non-motor manifestations are also present in Parkinson's disease, like sensory, cognitive, and autonomic abnormalities. So these are some of the important clinical features of Parkinson's disease, which is due to the degeneration of dopaminergic neurons in the basal ganglia nuclei. So basal ganglia, as I already mentioned in the previous slide, that is a group of deep subcortical nuclei that is located at the base of the forebrain, and it is mainly concerned with the control of movements and posture. So this is a frontal section of the brain that is showing the important nuclear masses in the basal ganglia. So the important nuclear masses in the basal ganglia includes, one is the caudate nucleus, which is a comma-shaped nucleus with head, body, and a tail. Then there is this putamen and the globus pallidus. Globus pallidus is having an internal as well as external segment. We call it as globus pallidus internus and globus pallidus externus. So this putamen and globus pallidus, they are situated lateral to the internal capsule, and they are collectively called as the lendiform nucleus. Then you have then there is the subthalamic nucleus, and followed by that there is substantia nigra, which is a large motor nucleus extending the entire length of the midbrain, and it is having two components, the substantia nigra, that is pars compacta and pars reticularis, and it is this pars compacta which is containing that major dopaminergic neurons, which will be innervating this caudate nucleus and putamen. You call it as the corpus striatum. So it is due to this massive degeneration of this nigrostriatal dopaminergic neurons that is leading to this various manifestations in Parkinson's disease. Now this basal ganglia, it functions in close association with the cerebral cortex, or it provides a feedback mechanism to the motor cortex in the initiation and control of the motor movements, motor responses. So if there is any abnormality within the basal ganglia, it can lead to severe motor disturbances, which is manifesting in this Parkinson's disease, which you can see as these motor manifestations. Now, regarding the management of the Parkinson's disease, it can be managed using conservative methods like levodopa, etc. But if the patient is not responding to these conservative methods, or if long-term conservative methods are producing certain side effects, you go in for surgical methods, and one option is deep brain stimulation in case of Parkinson's disease. And significant improvement in the symptoms of Parkinson's disease has been reported by using deep brain stimulation. So this French neurosurgeon Alain Benabin first introduced deep brain stimulation for Parkinson's disease, and the common structures that are targeted by deep brain stimulation, especially in Parkinson's disease and in other conditions, include, these are the important target sites. One is subthalamic nucleus, which is the most common target site for DBS in Parkinson's disease. Then globus pallidus internus also have showed significant improvement in the symptoms of Parkinson's disease. Then ventral intermediate nucleus of the thalamus. So this is mainly targeted especially in tremor dominant conditions. This site has been used for stimulating under deep brain stimulation. Apart from these sites, there are various other sites, target sites for deep brain stimulation, which is utilized in the management of other conditions. So these are the important target sites. Now coming to the mechanism of action, or how actually is this deep brain stimulation working. The exact mechanism is not known, but it is proposed that stimulation of this nuclei or the specific target structures in the brain can reduce the overactivity of this targeted structure, as well as it can reset the electrical discharges from these nuclei, and it can make them more regular. A regular pattern of neuronal discharge can be made by this stimulation. Plus, it can also correct the chemical imbalances which is happening within the brain that can lead to various conditions. So these are some of the proposed theories regarding how exactly this DBS or deep brain stimulation is working or bringing about the response. Now, coming to the methodology of the surgery. This deep brain stimulation, as I've told, it is a surgical procedure and it is usually performed in 2 stages. The first stage is the placement of this deep brain stimulation electrodes, DBS electrode placement. And this is followed by the next phase wherein you will be implanting the neurostimulator or that pacemaker-like device, what you call as the pulse generator. So usually they are done in 2 settings, one with a duration of 1 week apart. But in some cases, the surgeons will insert both the leads and the neurostimulator together also. But mostly after 1 week of electrode placement, this neurostimulator is implanted. Now coming to the first stage, which is the electrode placement, it includes or it follows a series of steps. One is attachment of a halo-like device, a head frame, you call it as the stereotactic frame, will be attached to the skull by means of screw, which help in immobilizing the head and provides coordinates or reference points to precisely localize the target sites. This is followed by a neuroimaging. More often an MRI or a CT brain is being done. So this will help in determining the exact distance of these target sites as well as in what direction and in what depth these targets electrodes have to be placed to reach the target sites. So once the target site is localized, this is followed by an incision in the skin and a drill is being used to make a hole in this skull, and the electrode is inserted and it is implanted in the brain tissue. And this is followed by a test stimulation for a few minutes, during which you are looking for any improvement in the symptoms or more often for any development of any side effects like abnormal sensations or movement disorders you are looking for. And if appropriate response is attained, the electrodes will be secured to the skull and the incision will be closed and the frame will be removed. So these are the few steps under electrode placement. So this is the first phase. So this is a diagram showing the placement of this stereotactic frame. And once the target site is confirmed, incision will be made and the electrodes will be implanted into the brain tissue. So this is the first stage of deep brain stimulation. Now the next phase is the placement of the neurostimulator, which is that pacemaker-like device, or you call it as the pulse generator. Usually this procedure is done 1 week after the initial electrode placement. Under general anesthesia it is done. And here a small incision will be made just beneath the collarbone where this pulse generator or the neurostimulator will be implanted. And this will be connected to the leads by a extension wire, which is an insulated wire, which will be tunneled all the way down beneath the skin from the head, neck, shoulder, connecting the leads to the neurostimulator. Now this neurostimulator or this pacemaker-like device, it is having an inbuilt battery and circuitry which will be generating the electrical signals. So usually it is not activated on the same day of surgery, but a few days later, like around 2 to 4 weeks after the surgery, the programming of this neurostimulator is done by the clinician of the practitioner. That is, the stimulation parameters regarding the appropriate pulse frequency, amplitude, etc. will be set by the specialist or the clinician. And attaining the best DBS settings, it takes some time. So frequent follow-up visits are often required for the attainment of the best DBS settings. So it is changed over time, and during the follow-up visits, it will be adjusted. So this is regarding the surgical procedure of deep brain stimulation. And now coming to some of the advantages or the benefits why people are choosing deep brain stimulation over various lesional procedures. So one important thing is it is adjustable and reversible. That is, this device can be programmed and reprogrammed based on the symptoms and as the symptoms are changing. And if there is some side effects or if there is any aggravation of the symptoms, you can even discontinue the stimulation. So that is, it is adjustable and reversible. Another is that it doesn't produce any damage to the brain, unlike any lesional procedures like palidotomy, thalatomy, which are also done in this treatment of Parkinson's disease. It doesn't produce any damaging effect to the brain, so future therapies can be advocated in such patients. Another is this DBS can be performed safely on both sides of the brain. Unlike certain lesional surgeries, if it is performed on both sides, it can lead to serious complications. So this can be safely performed on both sides of the brain. And finally, it can also help in reducing the medications these patients are taking. Significant reduction in the dosages of the drugs have been reported in patients who have underwent deep brain stimulation, thereby reducing or minimizing their side effects. effects. So these are some of the advantages that make the people choose deep brain stimulation over other surgical procedures. And as there is benefits, there are also disadvantages for this procedure. That is, there are certain related to device related, like the cost of the procedure, that is a bit high. Then there will be problems related to the repositioning of the probe, then wire replacement, then programming of the stimulator. It requires time to get the best settings for the this neurostimulator. So programming of the stimulator, it takes some time. So that is also another disadvantage. Then replacement of the stimulator. That is, these neurostimulator, they contain batteries and they have a lifespan of around 3 to 5 years. So you have to replace the battery. So again, a surgery has to be done, but it's not as major as the previous, what we have discussed, the initial surgery. So these are some of the device related disadvantages of deep brain stimulation. Then few complications which are associated with surgery, very less, but can lead to intracranial bleedings, headaches, infections, seizures are some of the complications that can occur associated with this surgical procedure. So these are some of the disadvantages. So to conclude, this deep brain stimulation is an alternative to the surgical interventions in the effective management of neurological conditions. And with the advancement in the medical field and technology, wider applications of deep brain stimulation have been reported, like in Alzheimer's disease, chronic pain, addictions, anorexia nervosa, restless syndrome, Tourette syndrome, and all. This deep brain stimulation has been advocated, and researches are going on how well this deep brain stimulation can combat these conditions. So that is regarding my presentation. These are a few references. Thank you.
Thank you, ma'am, for sharing an overview of what DBS is. Keeping this in mind, let me invite Dr. Krishnan Balagopal to share his valuable thoughts.
Yeah, warm welcome to our distinguished speakers and the primary target who are our students. So deep brain stimulation is a topic that has gained tremendous importance over the last many years, but is becoming more and more important today. So I think this is a very important topic which the awareness among our undergraduates is very poor. And I think this session predominantly aims to increase the awareness among our students. One of the important problems about DBS that we face is that the referrals that take place do not take place on time. So it is very important for the consultant doctors to know about this therapeutic option, which can be used in patients with moderate to advanced Parkinsonism, and refer the patients on time to people who are specialized in it and appropriate centers. So timely referral is, I think, the primary aim of this talk. So that is why the awareness of this topic among students should be increased. And we are very privileged to have two eminent speakers in this field here with us today, Dr. Sachin Suresh Babu from Mitra Hospital, and Sreeram, who of course I know personally from Rajagiri. So I think this talk has been structured into two parts. The first part will be looking at the physiological aspects of DBS. That is, what are the disturbances in the networks and how can stimulation modify and thereby change these networks, which is the basic pathogenesis in these diseases. So covering the first topic will be Dr. Sachin, who will be looking at the how neurostimulation modulates and changes the human brain networks. So without wasting too much time, I'll hand over the floor to Dr. Sachin. Over to you.
Thank you so much. Thank you. So, how to share this? Let me mute this. Okay. I wanted to share the slides, no? So, is there an option here?
There is a share screen option, sir, at the
Yeah, I saw
bottom.
it, but why the PowerPoint is not showing? Yeah, now it's showing. Yes. Is it showing now?
Yes, yes.
Yes.
Okay, let me put it in slides. Okay. Let's see. Is it showing as a full screen, the whole thing? Is it showing as a slide?
It's
So
still
it's
in
not on the
slides.
presenter mode.
It's not on full
Okay.
screen.
Now is it
Now
full
it's
screen? Okay.
yeah, yeah.
So basically, we are trying to understand how this deep brain stimulation works, right? So we had an excellent overview so far on what is deep brain stimulation. All just to recapitulate what we have just heard. I'm not going into all these details about the needs and all has been explained. Now, the FDA approved indications for DBS right now are in essential tremor, Parkinson's disease, dystonia, OCD, and epilepsy. Now, I don't primarily deal with the DBS as such, and that is why we have the expert with us, Dr. Sreeram. But there are some things about this DBS which actually interest me a lot, and that is why I agreed to take up this topic. And one of the main reasons, one of the main things that interest me is the mechanism that underlies the efficacy of this new modality of treatment, and how this efficacy of this treatment or this treatment and its mechanisms, how it paves the way for a larger understanding of the human brain itself. So that is why we are going to discuss it. Now, this is the usual phenotype of a DBS patient, a Parkinson's patient who requires DBS, which will be dealt more in detail by Sreeram. So I don't want to go into that. So this all has already been explained in the bird's eye view, and that also I will not explain. So there are different target sites for DBS. That also has been touched upon by the previous speaker, that for motor fluctuations, subthalamic nucleus, for tremor, VIM, and for dyskinesia, globus pallidus internus. So now let us come to the anatomy of the basal ganglia. And there is no point in talking about anatomy and physiology to undergraduates and all, because you all are much more well versed in all these things. But this is a like kind of a medial view and a lateral view of the basal ganglion apparatus. This basal ganglia and all, we used to refer to this, even now we call this as deep nuclei of the brain. This basal ganglia, thalamus and all, these are deep seated nuclei, and these are kind of relay centers. They are relay centers. And if you look at the thalamus, it is a miniature version of the human brain itself, which has representations of the entire cortex inside this mini structure. So these deep nuclei of the brain are extremely important because they are strategically placed and they are well connected. So that is the thing. So the connectivity is what makes them so special. And you can see that this is the caudate nucleus, and then we have there are some structures like she already mentioned about the globus pallidus internus and externus. These globus pallidus has two parts, the internus and the external segment. Actually, they have different connectivity, different networks. They are connected to different parts of the brain. So that is why it is, although it's a single entity called globus pallidus, there are two segments which are functionally also different. Then the subthalamic nucleus and the substantia nigra are very much, we can call this as basal ganglia, this as midbrain and all, but they are all functioning as a single entity. So the subthalamic nucleus, the substantia nigra are very much part of this whole nuclear system. And then we have there are certain other structures like which are nucleus accumbens, for example. This is as a part of the basal ganglionic apparatus, which is usually not very given much importance, but that is very important because of this connectivity to many of the limbic structures. And it has this is the anterior commissure, and the importance of the anterior commissure in relation to the basal ganglia in the context of DBS, I think, will be explained by Sreeram. So this is the MRI. If you look at the MRI, you can see how it is placed. It's much more easier if you look at this axial section. We can see the internal capsule, external capsule, and very safe within its perimeters. We have the lentiform nucleus and the caudate head. and the thalamus, and then we have the external capsule, and after the external capsule we have the claustrum, the insula. So this whole thing, the insula, the claustrum, the external capsule, the lentiform nucleus, this continuously in this axial view is very beautiful. And then we have the corpus callosum, the splenium posteriorly, the genu anteriorly. Then we have all the ventricular system. So this is one of the best views of the brain, which is almost highlights the entire diversity of the human brain and the structures, the deeper structures, which are very pivotal. Now, okay, so many of these structures, are very key. Pathologically, if you see, the caudate nucleus is very significant when you think about conditions like Huntington's disease. You think about conditions like Rasmussen's. These are conditions which specifically affects the caudate nucleus. So this view of the MRI, if you look at it, very important. If you look at the brain, and this axial section is very important because it will have many pathognomonic features in cases of various diseases. Just to mention a few of it, I think any of you know what is this? I mean, you might have seen this. Anybody wants to answer? What is this? This picture, this one, I think it is mentioned here. But what is this picture? Anybody wants to answer? No answers?
Students can please volunteer to answer.
This is a classical finding. It's a pathognomonic finding of a condition called Haller-Walden's disease, now called as pantothenate kinase associated neurodegeneration. This is called as the eye of the tiger appearance. This is because of iron deposition in the globus pallidus. So this is a classical appearance. So this is another appearance where you see in the midbrain and then in the thalamus, in the capsular region. So this is something called as a panda sign, which is seen in the Wilson's disease. So many diseases have very pathognomonic appearances on the MRI. That is why this basal ganglia, diseases that affect the basal ganglia have sometimes disease. Many times when you look at the MRI, you see something. We don't know what the disease is. You only know that this part is affected. But when you look at the basal ganglia, sometimes we have very cardinal findings. For example, this one, this is a negative peak. This is called as MR spectroscopy, where we look at the neurochemical, milieu of that area. And if you see a lactate peak, and this is a condition called as Leig's disease. It's a mitochondrial disease, Leig's disease. So I'm just trying to show that how important the basal ganglia is physiologically and pathologically in terms of diagnosis and everything. This is the pathways. You can see that it is mainly concerned about what is known as a mesolimbic pathway, nigrostriatal pathway, and the mesocortical pathway. So it's these pathways are coming from the from the brainstem going up. And if you look at the basal ganglionic connector pathways, initially there were actually three pathways which were important. These are called the sensory motor, associative, and limbic. And these are very well delineated pathways. We know how it goes also. It goes from the primary cortex, it's dorsolateral striatum, GPI. So everything is, although this is a small structure, the striatum also, for example, the nucleus accumbens is important for connection, the limbic pathway, and it is connected to the anterior cingulate and the median frontal areas. And if you look at the dorsolateral prefrontal and lateral orbitofrontal areas, they are connected to the dorsomedial striatum. And then we have the dorsolateral striatum, which is connected to the motor and sensory motor areas. So then it goes further down to the pallidum and the thalamus. So these are the main different pathways: sensory motor, associative, and limbic pathways. So previously whenever we studied physiology or anatomy and all, we always gave importance to what? We gave importance to the structures and relationships only. Like, for example, we will say that this is a basal ganglia, has three parts, this is a striatum, this is a putamen. But it is very important to understand the connectivity of these structures. It is important to understand the clinical pathways, the functional pathways, the anatomical pathways, because these pathways, the understanding of these pathways will help you to understand them better. So now we know that there is actually a fourth circuit also. This is called as the oculomotor circuit, which also it is mainly from the frontal eye field. So kind of if you see the entire frontal cortex and up to even the parietal cortex, the anterior structures, except for the posterior, everything from the central sulcus forward is connected to the basal ganglia. So now we go to a more traditional understanding of what we know as the direct and indirect pathways. I know that all of you know these pathways. Many times we forget this pathway. It's very, very easy pathway. You should not forget it. This is cardinal to understanding the whole basal ganglia, Parkinson's disease, everything. So don't forget this pathway. You should know this pathway. Even in sleep, if somebody awakes you, you should tell this pathway. As students of physiology, you should not forget this pathway. So how would you remember this? I usually remember it as, for example, either a striatum, I can put putamen also. So you have to remember that this is GPI. It is not GPE. This is GPI, and then this thalamus. So you just have to remember these three. So how I remember is SIT or PIT. You can call it a sit or pit. So the spit is there. Everything is draining into the spit, or you can just call it a sit also. So striatum internus and thalamus, or putamen internus and thalamus. So that is the cardinal. So the motor cortex is stimulatory to this pit. It is stimulating that pit, and that the pit, as you know, how pit is about darkness. No, pit is about depression and darkness. So everything inside the pit is depression. So you have all this GABA, all the inhibitory. The striatum will inhibit the GPI will inhibit the thalamus. Understood? But because of this double GABA, ultimately it is stimulatory. Despite this, whatever is happening inside the pit is depressive. What is coming out of the pit is stimulatory. It's kind of philosophical, spiritually, you can say. So from the thalamus, an excitatory input emerges to impact the motor cortex. So the motor cortex is ultimately stimulatory to the thalamus, and the thalamus is ultimately stimulatory to the motor cortex. But whatever happening inside the pit is depressive, GABA. Okay. Now we have an external pathway, which is also known as the indirect pathway. And how to remember that? That is very simple. You remember that you are not directly going into the pit. You want to escape the pit. So you are going outside. Outside means externally, or you are going under. That is sub. So sub means under. So external means outside. So I remember it as GPE and subthalamic. So these two, and then coming back to the globus pallidus. So the subthalamic nucleus is stimulatory. The subthalamic nucleus ultimately is stimulatory. Here also you can see the first two are depressive GABA effect, but ultimately the subthalamic nucleus delivers a stimulatory input to the GPI. And along with the GPI, you have to remember SNR, substantia nigra reticulator. And because GPI and the substantia nigra reticulator are kind of together, but when we are actually talking about the nigrostriate pathway, we are talking about substantia nigra compacta, and which is the one which has the dopamine coming out. And there is a difference in the effect of the nigrostriate pathway on the indirect and the direct pathway. That is because of the differential expression of the dopamine receptors. Among the dopamine receptors, the D2 receptor is inhibitory, while the D1 receptor and the other receptors mostly, which are all, I will show you those receptors, they are all excitatory. So the nigrostriate pathway is inhibitory to the indirect pathway. And the substantia and the nigrostriate pathway is stimulatory to the direct pathway because of the differential expression of the dopamine receptors, D1 in direct and D2 in indirect. Hope you understood. And this is the same thing. So there is, nowadays, people also say there is a hyper direct pathway, and I'm not going to go into that. There is a direct pathway from the cortex to the subthalamic, which is called as hyper direct pathway. Now, if you see the dopamine receptors, this is the vesicular monoamine transporter. This is the dopamine transporter DAT. These transporters are important. Why? But there are scans which are, nuclear scans which use this dopamine transporters, the DAT scan, the TRO-DAT scan, the fluorodopa scan. So these receptors and this dopamine and all, there is a new modality called as fluorodopa PET, and then we have this TRO-DAT scan which uses these receptors, these these transporters to scan and understand, the early phases of Parkinson's disease. Now, these receptors are all there in the postsynaptic, but there is one, the presynaptic D2 receptor, which is inhibitory, while others are all stimulatory. That is because of the binding. If it actually binds to the G5, GS alpha subunit, and this is the GI. G stimulatory, GI is inhibitory. So the GS stimulates adenylyl cyclase and producing more of GTP and all. The other is inhibitory, adenylyl cyclase is inhibited. So that is the difference between a D1 and a D2 receptor. So what happens in this is actually an animal model where MPTP, is MPTP injections, chronic MPTP injections can produce Parkinson's disease. What it does is that you can see the nigra, the substantia nigra, just melts away. So this dark nigrate part of the substantia nigra just goes away. Now, if you look at the parallel in Parkinson's disease, actually this is a particular type of scan, SWAN sequence, where you will see, you can see this in only in 7 Tesla, sometimes in 3 Tesla. You can see there is a lucency in the substantia nigra. This lucency is normal. It is called as a tail of the substantia nigra. You can see some brightness in the tail of the substantia nigra, and that is because of there's a cluster of dopaminergic neurons called as nigrosomes. Now, these nigrosomes are normally present in the tail of the substantia nigra. When the nigrosomes start disappearing, then the Parkinson's disease starts. So the more and more nigrosomes start disappearing, this tail actually disappears. And the tail actually disappears, it becomes like a simply black. So this is not, this is a scan, okay? This is not pathologically the nigrate part. So these are a kind of scan which shows this absence of this tail. So this is called as a normal tail, is known as a swallowtail appearance, and the swallowtails that split in that swallowtail starts disappearing as Parkinson's appear. The swallowtail appearance of the healthy nigrosome. So this is a new word which you have to remember, which you have to study also. It's called as a nigrosome. The importance of the nigrosome in Parkinson's disease is something to read about. So if you look at a very simplistic view of Parkinson's disease, the pathophysiology hallmark of Parkinson's disease is hypokinetic signs. Means bradykinesia, rigidity, all those things. This is because of excessive inhibition of the thalamocortical and brainstem motor pathway. So why the thalamocortical is inhibited? Because there is an indirect pathway gets more, indirect pathway is more active and the direct pathway is inhibited. So that's a simplistic view, that because of the Parkinson's disease. But if you look at the things like dyskinesia and all, you see that it is not that simple. There is an overactivity of direct pathway can coexist with the indirect pathway overactivity also. So it's complex. It's not just A plus B. So this is to show that what happens in hypo and hyperkinetic is complicated. So now you see this patient with Parkinson's disease. You can see that hand movements and some lip movements happening. Overall, if you see this patient, she is hypokinetic. She is not having much associated movements of the hands when she walks, but she has some movements in her facial region, around his lips and all, and there are also some movements of the hands, right? So these are dyskinesia. So if you understand this, basically all this is a result of what is happening in the direct and indirect pathway. So it is very important for us clinicians also, and for you also, to everything is connected to the physiology, pathomechanisms and all. So whatever clinical expression you see, it's an interesting, ultimately, I think there will be a day when we will understand the pathomechanisms, and the pathomechanisms will be linked to the treatments that we choose. Now, for example, nowadays, how do we treat? We treat basically on, what is the clinical, how many seizures, or how many for epilepsy, or you had a patient had a stroke, we just go and, okay, we treat it as stroke, we treat it as epilepsy, we treat it as Parkinson's disease. But the ultimate treatment solutions that are coming in the future would be an understanding of what is happening in that patient, what is happening in the pathways, what is happening in the genetics, what is happening in the neurochemical milieu, and then you will be, I mean, the day will come when there will be a very customized treatment plan for each and every patient based on all these things. Now, if you look at the history of DBS, which already mentioned, you can see that actually the first person who started doing very aggressively DBS is the person called Robert G. Heath. There's an article, I think, in Lancet about this, and then it's called the pleasure shock. So basically, this guy was doing a lot of, I mean, very, very notorious kind of stimulation, where he was stimulating to see all kinds of things inside the brain. He was stimulating multiple structures. He stimulated a lot of white matter. He stimulated, all kinds of experiences by stimulating the brain. He was using sometimes direct electrical stimulation. But a very methodical pathway for many methodical, clinical protocol was developed by this French neurosurgeon called Alain Louis Benabid, and then the French are very good at this. If you look at the French are the ones who made this. About the stereotactic atlas, the Thylorac and Bencard, that they actually, even in an era when there was no MRIs to help them, they made an atlas. I mean, the trajectory is like the Earth, the latitude and the longitude is there. They have made a trajectory and coordinates for every part of the brain, so that you can make a pathway and then enter the brain and then land at the exact location. So that is beautiful. Actually, that is used in epilepsy. That same principles are used in many parts of neurosurgical procedures. So, the most common site we do is the subthalamic nucleus. Now, this is an interesting picture. I just put it, I don't know, like Sreeram will be able to tell you more about it. Sometimes they put it in a slightly, they try to stimulate the sona inserta also, the dorsolateral subthalamic nucleus and the sona inserta also. There can be monopolar and bipolar stimulation fields are shown here. So this is a new concept that how to stimulate. The stimulation can be, the fine tuning of the stimulation will go on improving over time. How to capture the white matter tracks also. That is, mainly we always think about nuclear stimulation. Now we know that the white matter is very important, and how to harness into that white matter potential. So mechanism for DBS it's manifold. It is not just a single kind of mechanism. So there is a direct electrical neurochemical effects, modulation of oscillatory activity, synaptic plasticity, neuroprotection, and neurogenesis. These are the main heads. Now, why different mechanisms? How do you know different mechanisms? The actual proof for the different mechanisms comes from the fact that the immediate effects are due to neuromodulation, intermediate effects are due to synaptic plasticity, and long-term effects are due to anatomical neuronal reorganization or remodeling. And how do we know it is true? Because if you look at the various conditions and their response to DBS, some of them respond instantly, some of them take time to respond, some of them take a long time. For example, the axial symptoms respond after some time. That is because of the neuronal reorganization. If you see in epilepsy, whether it be vagus nerve stimulation, deep brain stimulation, the seizure frequency comes down over time, over a period of months. And that is because the neuronal reorganization of the pathways is very important. Now, if you look at neuronal plasticity is very important mechanism in tics, for example. So that is, so it depends because of the various mechanisms are there for various pathologies. That is why the latency to response is different. So the neuromodulation is a very simple thing to understand. So first and foremost, there can be a somatic inhibition, just like a lesioning effect. You're producing high frequency stimulation. This can cause sustained depolarization. So the sodium channels are inactivated. There's an increased potassium channels preventing the initiation or propagation of action potentials, which we learned in physiology, like what is known as the depolarization block. I think depolarization block when we studied, I think organophosphorus poisoning or something like that. We studied the concept of depolarization block. The inhibition can be through synaptic mechanisms also via GABAergic interneurons. Now the second one is very interesting, the activation of the axon on dendrites. The axons and dendrites have a lower stimulation threshold than soma. So what may be inhibitory to the nuclei may be stimulated to the axon. So the white matter fibers and afferent pathway stimulation may in fact contribute to the neuromodulatory effects of DBS. So one side there may be inhibition happening to some structures, there will be stimulation of certain cardinal white matter pathways. Ultimately, there is a regularization of the neuronal activity, allows information transfer in a fruitful fashion to the basal ganglionic circuitry and the cortico-subthalamic pathways. So there is the information transfer. If you see, we think about ions and all those things, no? We think about ions, neurochemical, this happening, calcium, those things we think. But ultimately, the net result of this is information transfer. Information is getting transferred from one point to other inside these neural networks. That information transfer, these very minor alterations in these neurochemical structures, in this ionic milieu and all will prevent this fruitful transfer of information, and that fruitful transfer of information is ultimately affected through neuromodulation. That is what we understand. Now, neurochemical effects. So there it is just not just acting through the the information mechanism or the sodium channels and all. It may be the actual chemical that is released by the neural stimulation itself may be producing the effect. For example, the anterior nucleus, the centromedian nucleus, the thalamus and hippocampus are sometimes stimulated to produce DBS as used in epilepsy, chronic epilepsy. This is a study called Sante. So they used all this thalamic nuclei and hippocampus rarely. So there they are exploiting the neurochemical effect of DBS. By chronic stimulation, they are stimulating the release of adenosine, which is an inhibitory substance which will prevent seizures. Adenosine is supposed to be a calming thing. The more adenosine you have, the more calm you are. So the adenosine is now another molecule which is coming very important neurochemically, previously less well understood, now a lot of role. So that is another thing that you can read about. One thing I told you can read about the nigrosomes, and adenosine is a new thing, it's something new. Now this is I don't know whether it will play.
जिया जले जा जले मैनू तले धुआं चले धुआं चले रात भर धुआं चले जानू ना सके रे जिया जले जा जले मैनू तले धुआं चले रात भर धुआं चले जानू ना सके रे
If I play more than this, no, I may not like it anyway. So we'll go to the next slide. So So basically, this is very important. So if you look at this, I chose this very purposefully. This song by A. Rahman, G. If you can see that this is exactly what is happening inside the human brain, and this song actually exemplifies what happens inside the human brain. Oscillations are a hallmark of normally functioning neural networks in the mammalian brain. So what happens is a temporal dynamic summation or coherence of local, regional, or remote neuronal populations. You think about all the people with various instruments, and they are like different neural, nodes, you can say, and I mean, for example, at one point you can see the flute person and the other person cohering. They are that cohesion takes place at different frequencies. Sometimes the different people are coming together, or different frequencies are coming together. So multiple network oscillators are aligned in parallel and series to generate the desired neural state and function. Now, oscillations occur at certain set frequency bands in different neuronal networks. So physiological oscillations are different from pathological in terms of frequency and other network characters. In other words, previously we used to think about a human brain as static, just like you look at a transformer, you go and open the transformer, you see a lot of connections, a lot of wires going on. That's all we knew. Now we know that the human brain is more dynamic than that. There is every function you can think about, even the contemplation, even normal contemplation. You are just thinking and sitting and having a nice time with yourself. You need something called as a default mode network to do that. And then there are different networks to ruminate on autobiographical content. There are different networks to the scientific content. So the human brain is a rich collection of networks, and these networks are not again static networks. They will come together in different manners, different intervals, both temporally and spatially, at different frequency bands to produce different effects or different functions. So that I thought is the most amazing thing about the human brain and these oscillations. Now, what happens in Parkinson's disease is primarily these oscillations are abnormal. So there is an enhanced oscillator, there is an enhanced rhythm in the 4 to 8 hertz and 30 to 30 hertz in these basal ganglionic structures. And there is an unwanted orchestration of cortical rhythm. So these is the two things. There is a corticosubthalamic and cortical GPI coherence is unwanted. They're coming together and producing music when it is not wanted. They're not going according to the plan, according to the music script that is written. And the idle rhythm, if you say, this is also a normal rhythm. Normally when you are resting, you need this rhythm. But in Parkinson's disease, the beta band oscillations are present. Normally also beta band oscillations are there. They are essential during resting state and tonic contraction. But as soon as voluntary motor activity is initiated, they decrease and are replaced by higher oscillations. That is what happens in a normal band. Sometimes they go into the higher frequency bands. Now, this HFOs, they're called high frequency oscillations. Now, this is the third thing I wanted to read about. One I told you is the negrosomes. Second, I told you adenosine. Third is high frequency oscillations. Previously we thought of what? We thought of alpha, beta, gamma activity. Gamma activity stops at 80 hertz. What about more than 80 hertz? 80 to 250 hertz, then 250 to 500 hertz. These are called high frequency oscillations. These are not usually produced by what produces the alpha activity, for example. That is because of the summation of the postsynaptic potentials, right? Now, what happened? How is high frequency oscillation generated? It is because of axon to axon communication or the gap junctions. We have traditionally believed that neurons communicate through the synapse, right? Now, these high frequency oscillations happen because of connection, because of axon to axon communication through gap junctions. And this is a normal phenomenon. And this normal phenomenon is very important for, highly evolved activity. But sometimes these high frequency oscillations can be seen abnormally also, especially in epilepsy. And now beta band oscillations are very high, abnormal in Parkinson's disease. The beta band bursts or the BBO bursts are more coherent, more prolonged, more widespread. And they also there is some entrainment of HFOs to local beta band rhythms. In other words, just I told you, HFOs are not supposed to be entrained. The HFOs are not supposed to be entrained by local beta band populations. And this abnormal, this is called as bad music. So there is a bad music going on. So, this is something which is, I think this is some of the very I mean, Sreeram's primary area to understand. We can actually put microelectrodes or microelectrode to study this networks. Actually, these microelectrode recordings are very crucial to understanding this. We use it in a therapeutically. We use it for some small indications, but ultimately, if you look at the research potential of this, it's immense. It's huge. So there is a prolonged and high amplitude beta burst from normal to PD state. So as the PD progresses, Parkinson's disease progresses, these beta bands, these beta bursts become more and more aggressively prolonged. And so it is correlated with the disease severity as well as it is correlated with disease progression. That is why these beta band oscillations are considered to be a biomarker of this Parkinson's disease. And there is also a difference between the on phase and the off phase. A long duration beta bursts lead to a stronger phasic synchronization within the motor region of the subthalamic nucleus, which is related to the impaired movement in Parkinson's disease. So what happens is that when there is a long duration beta burst, there is a stronger phasic synchronization within the motor region of the subthalamic nucleus. In other words, the subthalamic nucleus, the output from the subthalamic nucleus, which is very crucial for the corticothalamic pathway, it is not delivered in a very smooth fashion. So that is supposed to be causing the bradykinesia. Now, what happens in DBS is that the DBS try to override and sometimes modulate and change these beta band oscillations in a positive manner by reducing the coherence between these abnormal oscillations and the normal oscillations. Sometimes getting rid of the beta band oscillations itself by giving high frequency stimulation. And so that is a main mechanism of DBS. There are so many other mechanisms that are being considered. The DBS can activate the astrocytes. They can also activate the neurons, release excitatory input, and this excitatory input can affect the cerebral blood flow, and this is known as neurovascular coupling. So that is a new mechanism. And then with the neurochemical hypothesis I told you through adenosine, so neurovascular, neurochemical, electrical. So all mechanisms are exploited. And there is also neural protective theories. As of now, you must know that in early Parkinson's disease, we do not use DBS, but there are people who think that DBS at some stage of disease can slow the progression of the pathology by protecting dopaminergic cells. This is a controversial thing, but this can be because it increases the production of glial cell line-derived neurotropic factor. And then finally, there is another mechanism called as electrotaxis. It means the progenitor cells will migrate towards the DBS current, they believe. So when you have a stimulation happening one place, then the progenitor cells will come to that place and probably replenish the lost neurons. So there is also genetic expression, and there is also neuronal plasticity at a molecular level. And all these things are now coming up to understand. These are all like a larger role of stimulation. So stimulation will ultimately stimulation, gene therapy, everything will be combined together for various diseases. It is not just the conventional targets that we are going to stimulate. We must stimulate the white matter. We are already stimulating the corpus callosum. We are stimulating the cerebellum. So how all these things will come together in the future is it's very difficult to guess. But it is a very promising, very interesting area if you look at it from the point of view of a physiologist or from the point of view of a neurologist. I think I have shed some light into all these things. Sorry if I was, unclear on certain things. Thank you.
Thank you, sir, for your valuable thoughts. With equal pleasure, I invite Dr. Sreeram Prasad for the session on deep brain stimulation for Parkinson's disease.
Can you see my slides?
Yes, sir.
Yeah, yeah.
Now I have put in screen show. So is it visible now?
Yes, it's visible. Yes.
Yeah. Okay. Shall I start?
Sure, sure, sure,
Yeah.
doctor. Go.
Good morning. I believe it's good afternoon after it's 6 past 12. So, first of all, I thank the Physiology Department, M.O.S.C. and Dr. Annie for this wonderful opportunity. And it's always a pleasure to present with my dear friend Dr. Krishnan as at the chair. When I was asked to give this presentation, basically I have never given a presentation to an audience like this because I understand that the target audience primarily is are the first year students of physiology students of M.O.S.C, right? So I was actually confused how much I should talk, what all things I should present, I should not present and all. But after the talks of Dr. Neena and Dr. Sachin, I don't think I have to give this presentation itself because they have covered most of the things that which I wanted to talk. And it's always a difficult job to present after Dr. Sachin because your presentation will always be overshadowed by Dr. Sachin's presentation. Anyhow, basically that's why I'm a great fan of Dr. Sachin right from the days of my house agency at Trivandrum Medical College. Anyhow, without wasting my time, I will go to the presentation. I have been asked to talk about deep brain stimulation for Parkinson's disease. So basically, I'll be talking and I will be presenting this talk in two halves. The first half will be about Parkinson's disease, and the second half will be about deep brain stimulation. When and why we should do deep brain stimulation for a patient with the Parkinson's disease. I hope my slides are visible again. Once again checking. This is my first slide. So, coming to what is Parkinson's disease? Basically, when we think about this disease, it's a degenerative disease of the nervous system. So, first, then we have to understand what is this degenerative diseases. Degenerative diseases are a group of diseases which occur in all parts of the body, in all systems of the body. And what is degeneration means? With aging, all parts of our body will have loss of cells. That is normal for aging. But when cell loss occurs out of proportion to what is expected for aging, then it becomes a disease, and then it is called a degenerative disease. Parkinson's disease is obviously not the only degenerative disease occurring to human beings. Basically, it can occur in different parts of the body. For example, a classical example is osteoarthritis of the knee, which is degeneration of the knee, and there are degenerative disease of the heart valves and things like that. Degenerative disease also occur in the brain. And another example of a well-known example of a degenerative disease of the brain is Alzheimer's disease, and that is the most common degenerative disease of the brain. And Alzheimer's, as we all know, presents with the dementia or cognitive issues, right? And Parkinson's disease is the second most common degenerative disease of the brain. And when we think about degenerative disease of the brain, we also have to know that in none of these diseases, the whole brain gets degenerated. Basically, this degeneration predominantly occurs in one part of the brain, and that will be responsible for the symptoms because that depends upon what function that particular part of the brain is doing, right? So in Parkinson's disease, what happens is, as Dr. Neena was telling, there is loss of dopamine secreting nerve cells in the brain, and it has been shown that by the time a patient becomes symptomatic, by the time a patient's symptoms of Parkinson's disease begin, like tremor, around 70 to 80% of the dopaminergic nerve cells have already died. So immense is the reserve of the brain that only after around 70 to 80% death of the nerve cells, they become symptomatic. And when we talk about degenerative diseases, all degenerative diseases has got two features. One is that it's a chronic disease. Chronic disease means it's a long-term disease. It persists throughout the life of the patient. And second feature is that it's a progressive disease. Why? Because degeneration will progress over years, right? So the disease will also progress over years. The symptoms will progress over years. The disability progresses over years. So these two factors we have to keep in mind. And Dr. Neena was told this actually. The first description was of Parkinson's disease in modern medicine was done around 200 years back, more than 200 years back, by none other than an English doctor called Dr. James Parkinson. Basically, in this essay, he described around 6 patients with Parkinson's disease, and he called the disease as shaking palsy, a disease where there is shaking or tremor, and the patient has got difficulty in doing activities. So, and later, after the death of Dr. James Parkinson in 1876, the well-known French neurologist by name Dr. Charcot suggested that this disease should be named after Dr. James Parkinson, and the name came into existence in 1876. And coming to a bit of epidemiology, when we think about Parkinson's disease, when any of us think about Parkinson's disease, the natural picture which comes to our mind is an elderly person person sitting with a mask-like faces and with a drooling and having some tremor, right? So that is true in a large extent because it is usually a disease of the elderly or 50 years of age. The chance of Parkinson's disease increases, and it has been shown that more than 50 years of age, around 1% of the people has Parkinson's disease. But when the age crosses 65 years, around 1.8% of the people have Parkinson's disease, and as the age crosses 85 years, the chance of the prevalence of Parkinson's disease in the society is around 2.6%. So there is a big meaning for this for these figures because of the advances in the healthcare facilities and because of the general increase in the development of our country, the life expectancy of our society is increasing, right? So when the life expectancy of the society increases, a disease which the prevalence of which increases with the advanced age, we are likely to see more and more Parkinson's disease patients in the society as years pass by and as development occurs and as the age expectancy of the society improves. This is one answer to the question which many people ask, why we are seeing more and more Parkinson's disease in these days. There are other explanations as well, but this is one explanation too. And but having said that, it is a disease of the elderly, but it can also occur in people of young age group as well. There's a specific entity called young onset Parkinson's disease when it occurs when it starts less than 40 years of age. And these are some of the eminent personalities of the world who has developed Parkinson's disease. If you look at on the top left is Yasser Arafat, the founder of the Palestine movement. And if you remember his old videos when he was giving shaken to world leaders, and we could see that his hand was shaking. And the other is Pope John Paul II, who also had Parkinson's disease. If you look at his old videos giving mass and his hand was, and we can see that his hand was shaking. Then the well-known boxer Muhammad Ali, who died around 5 or 6 years back, he had Parkinson's disease at a relatively younger age. And on the top board and on the extreme bottom is Michael J. Fox. Many of us may not know him, but he's a very famous Canadian actor who developed Parkinson's disease at a very young age. And he, from that time onwards, he made a foundation called MJ Foundation, which has been actively involved in the research of Parkinson's disease in different parts of the world. When I was in Toronto, actually, many of our projects were funded by this foundation. MJ Foundation. Then we'll leave it there and we'll go to features of Parkinson's disease, some clinical aspects. When we look at Parkinson's disease, basically we all know that, and we have talked that it's a movement disorder. But it's not movement-related symptoms alone. Parkinson's disease patients have got many non-movement-related symptoms as well. So the Parkinson's symptoms are broadly classified into two. One is motor problems, or otherwise movement-related problems, and the second is non-motor problems or non-movement-related problems. So first we look at motor problems. When we look at motor problems, they are again divided into two: cardinal features and other motor problems. But there are four cardinal features or cardinal motor problems, which are probably the most important symptoms of Parkinson's disease. We'll start from one by one. First and foremost is shivering or tremor. Usually this tremor starts on one part of the body and usually in the one hand, and usually this occurs at rest, and I will show a video later. And the second common symptom is stiffness of limbs, which we call rigidity. And third is slowness of movements, and Sachin are told that this is the most important feature of Parkinson's disease. Correct? Why? Because without this symptom, slowness of movements, which we call bradykinesia or echinacea, we are not expected to make a diagnosis of Parkinson's disease. In other words, it is a hypokinetic movement disorder in which movements are reduced. So this is the most important feature. And the fourth cardinal feature is loss of balance, which we call postural imbalance. And combining the first four letters the same amount of tremor, but he heads up the company. He's a businessman. He has to attend a lot of business meetings, and the tremor during such meetings becomes socially embarrassing and all. Then we may have to treat the same person if he's having a high activity life. So basically, that depends upon how that disease affects their activities of daily living. I will not go into the details of treatment, but I will mention only levodopa, which is the most important medication for Parkinson's disease. And all patients with Parkinson's disease will have to take levodopa at some point of time in their life. And levodopa is nothing but dopamine that goes to the brain, crosses the blood-brain barrier, goes to the brain, and gets converted to dopamine. And when we think about treating levodopa, patient Parkinson's disease with levodopa, there are 3 stages of treatment. Why this is important is because this has got some connection with the why we are doing DBS. So basically, in the initial phase of the disease, during the first 4 to 5 years of the disease, when we give 3 doses of levodopa, morning, afternoon, and evening dose of levodopa, they get round-the-clock benefit. They got 24-hour benefit, and they get a decrease in their symptoms. Their activities of daily living improves, and they lead a normal life. And they don't even know that they have this disease. But after 4 to 5 years, a second stage of the disease will come, which is called phase of motor fluctuation. In other words, what does it mean? There is fluctuation in the motor symptoms, right? And that depends, and that is dependent upon the duration of action of levodopa. When after around 4 to 5 years of disease or so, the duration of levodopa comes down from 6 hours to say 5 hours or 4 hours and on. So at this stage, the patient will know the time when the levodopa is acting on him or is helping him, and the time when the levodopa is no longer acting and is not helping him. So when the time during which the levodopa is acting is called on time. During this time, naturally the symptoms will be less. Their tremor comes down, there becomes more, their activities improves, their speed of movement improves, and things like that. But once the effect of the medication goes off, wears off, and this is called off period, all their symptoms come back. They develop their tremor back, they get their bradykinesia back, they get their postural balance back, and their activities of daily living are affected, and affecting their quality of life. And after around 1 or 2, when this is advances for 1 or 2 more years, they develop the third stage of the disease, which is called dyskinesia. Dyskinesia, as a name indicates, this means disordered, and kinesia means movement, which is abnormal movements. They start developing abnormal movements, and these abnormal movements are basically produced by levodopa. They are the adverse effects of levodopa. And during the irony is that these people can work, or they can do their activities only during the on phase. During the on phase, at some a few hours of the on phase will be shadowed with this dyskinesias, the period of dyskinesias. So because of this dyskinesias, again they can't do their activities. For example, if you look at this video, this patient with advanced Parkinson's disease, this patient has taken levodopa. Just observe this patient, the abnormal movements which she is producing. This is levodopa induced. So imagine this patient. In the off time, she can't do anything. In the on time, when the medication is working, when she is expected to do her activities, she develops such abnormal movements, and again she can't work. This patient was working in a bank, and we did DBS for her. Okay, and so this is the time when we think about DBS, when medications are no longer giving optimal benefit to the patient. It's not that medications are working. Medications are working. Levodopa still works, and there will be few hours at least in a day when levodopa is working and is helping the patient. But most of the time, they will spend either in off state or in on state with the dyskinesia, which is again disabling. So this is the time when we think of helping these patients by other means like deep brain stimulation. So the rest of my talk will be on deep brain stimulation, and when we try to when people have explained this already, but when you try to, some people have tried to define it as stereotactically targeted. Stereotactic means this is a surgical technique which is used for doing deep brain stimulation, about which I will come to later. So it is stereotactically targeted application of chronic and reversible electrical current. Chronic means it is long term. Once DBS has been put on a person's body, this can be used throughout his life. And this is reversible. As Dr. Nina was talking earlier, just switch off the device, that stimulation is gone. So that is reversible. A reversible electric current is given to focally to neural elements. It's not that the whole brain is stimulated. We are targeting a small area of the brain which is our interest, which is of interest for the patient, and we are applying a current to that focal area. And what is our aim? And by DBS, what we aim is we aim to alter the function of these structures. Basically, this is called a functional neurosurgery. There is absolutely no structures are removed. When we talk about a surgery to a patient, first impression that comes to a patient is that, for example, if the patient has got a brain tumor, you do a surgery and remove the tumor. If a patient has got a clot in the brain, you do a surgery and remove the clot or a bleed in the brain. But in this case, we are not removing anything from the brain. We are actually introducing a device to the brain to change the function of these structures. That is, it is called a functional surgery. And either in isolation, either we are changing the function of that area alone, or in relation to the role with the larger networks of circuits. Dr. Sachin has beautifully elucidated the circuits and the role of these nuclei in the function of the circuit. So by changing the function of these structures, we can change the function of the circuits in which it is involved in, and we can bring down the symptoms of diseases. And history, many people talked about it. It started in 1993 when a group from Grenoble, France, first reported subthalamic nucleus deep brain stimulation in patients with the Parkinson's disease. And after that, it is estimated that more than 1 lakh patients, and I believe now around more than 1.5 lakh patients, have received DBS electrodes throughout the world. So coming to the indications of deep brain stimulation, Dr. Nina talked about this, but I'll just touch upon this again. The most important indication is movement disorders. More than 90% of DBS is still done in patients with movement disorders. And again, the most common indication being Parkinson's disease, about which I am going to talk further. And second is dystonia. As Dr. Nina told, dystonia is a disease where there is abnormal posturing or twisting of the limbs. And then tremor. It's not, Parkinson's disease is not the only disease with the tremor. There are many tremor diseases, essential tremor being a classical example, and DBS helps such patients. Tardive dyskinesia. Tardive dyskinesia means basically it is a adverse effects of the psychiatric medications or some medications used for dyspeptic symptoms by gastroenterologists. These drugs can sometimes produce movement disorders, including dyskinesias or dystonias, and such conditions can be helped by deep brain stimulation. And Tourette syndrome, another movement disorder where there are tics or abnormal movements called tics, and when that is severe and not amenable to medications, DBS can help. And other indications, second most common indication, psychiatric diseases like OCD, an approved indication for deep brain stimulation. And depression, people have tried deep brain stimulation with the variable results in people with drug-resistant depression. It has also been tried in people with diseases like anorexia nervosa, epilepsy. Sachin sir talked about it. I will not talk anything about that now. And in some pain syndromes also, which are resistant to medications, we can think of doing DBS. Now, how to do a DBS? DBS is not a single man's work. Actually, it's basically we need a team to do a DBS. It's not about DBS alone. Most of these advanced treatments in most of the specialties requires a team, and the movement disorder specialist is the lead of that leads the team, or it's at the core of the team. But but neurosurgeon's role is extremely important on the day of the surgery. Then we need the help of neuropsychiatrists, neuropsychologists. Why, I will tell you later. We need neuroanesthesiologists in the team, neuroradiologists to interpret the scans and things like that, and we need supporting staff like DBS nurses and all. So this so with this team, how will we do a DBS? The single most important step and the first step of DBS is candidate selection. DBS is not a surgery which can be done in all patients with the Parkinson's disease. There are patients who will improve with the DBS, and there are patients who are not likely to improve with the DBS. So that is extremely important. If you choose a wrong candidate, they are not likely to get the benefit, and we are likely to see an unsatisfied patient after DBS. So basically, we need a diagnosis of a levodopa responsive Parkinson's disease. This is very important. And then, as I told you earlier, the second and third stage of the disease, they should have started at least fluctuating, but they may or may not have dyskinesia. But at least after the patient starts fluctuating, we take them for DBS. Why? Because during the early stages, when the patient is not fluctuating, they can very well be managed by drugs alone. Then why should we subject them to a procedure just got its own risk as well, right? So in the early stage of disease, this is not done. It is done at least after the patient starts fluctuating, and usually a disease duration of more than 4 years is kept as a cutoff. Sachin sir talked about this. So basically, in nutshell, it is a treatment for advanced Parkinson's disease, and at that stage, most of these patients are at a stage where drug therapy has always been optimized, but still the patient has got significant symptoms, and their activities of daily living are affected, and they have got a poor quality of life. So basically, we do this surgery to improve their activities of daily living and their quality of life. But as I told you earlier, this is not a surgery for all patients with the Parkinson's disease. There are definite contraindications. One is dementia, or probably the single most important absolute contraindication for DBS is dementia. Why? Because in a person who has already progressed to a state of dementia with the Parkinsonism, then what quality of life are we going to improve with such a surgery? Basically, this is basically to improve their activities of daily living and their quality of life. And again, to manage a patient with a dementia who has got a DBS for programming and things like that, it's not that easy. So basically, dementia is an absolute contraindication. There are no other absolute contraindications, but though there are precautions. For example, age. Usually, DBS it is best done in patients below 70 years of age, because as age advances, the chance of complications increases. And it can very well be done up to 75 years of age. But after 75 years of age, you have to be extremely careful. In my experience, I have only one patient whom I have done after 75 with the Parkinson's disease, because he was otherwise cognitively well preserved. Then coming to psychiatric issues, mood. If there is an unstable depression with a suicide risk, we have to treat them and we have to improve their depression, and then only we have to take the patient for DBS. And again, psychosis, which if there's psychosis which is refractory, not responding to medications, then we have to wait. We have to treat them with the medications. We have to improve them, and then only we should take them for DBS. But there's an exception. The psychosis can also occur as side effect of medications, right, which we use for Parkinson's disease. So if it is a drug-induced psychosis, then we may consider DBS, because the drug dosage is going to come down after DBS and their psychosis may improve. So then coming to how we do the DBS and after candidate selection, we do something called a pre-operative evaluation. We do two things. One is called a levodopa challenge test. The other is called a neuropsychological assessment. Why levodopa challenge test? I told you that they should have a levodopa responsive Parkinsonism. So in this, what we do is we call them early in the morning and ask them to come without taking medications. So they come without taking medications, and we assess them with some scales called the UPDRs and all. Forget about it. But then we give the medication to the patient at the clinic itself, and then once the medication starts working, that is once the patient turns on, we again reassess them, we again redo the scales and see how much response they have got, and then also it helps to identify side effects like dyskinesia, postal hypertension, things like that. This can be documented. Then we send them for a neuropsychological assessment. Extremely important. Why you should know by this time, because we have to look for dementia, as I told earlier. We have to look for an unstable mood. We have to look for psychosis and things like that, which can be made through a neuropsychological and neuropsychiatric assessments. And once the patient satisfies these criteria, and once the patient does not have any major contraindications, we take them for DBS. Then where are the targets? Targets, actually, Dr. Nina already told. We have three major targets. One is thalamus, the other is globus valgus internus, and the other is subthalamic nucleus. And thalamus is basically done for tremor, not for Parkinson's disease per se. Basically, it is for tremor. For Parkinson's disease, you do two targets. One is GPI and the other is STN. There are definite indications for GPI and STN. I will not go into that because that is outside the scope of this discussion. And coming to GPI, in a GPI is also DBS is also done for dystonia. But for Parkinson's disease, we can either do DBS at the GPI or the subthalamic nucleus. And then how to do this? Basically, what we have to do on the day of surgery, we have to put this device on the body of the patient. Right. These are three different companies. We supply the hardware, and the most commonly used is Medtronic, and we have Medtronic and Boston Scientific available in India. And this is the lead which is put inside the brain of the patient, one on each side of the each half of the brain. And then this is the neurostimulator which is put on the chest wall. And how to do this? Basically, this is, as I told you earlier, the surgery. This is surgery is called stereotactic surgeries, and the technology which is used for doing such surgery is called a neuro navigation. And the first thing we do is targeting. We have to find out which part of the brain we have to stimulate first. For example, if you are selecting the STN, then we have to target the STN, right? And this is very critical in the accurate planning of DBS. And what we do, basically, we require very high quality imaging, and we do always do a pre-op MRI, without which we can do DBS. And after doing the pre-op MRI, we then do the targeting. This picture on this side shows the STN here. This is the lateral aspect where we have the internal capsule. This is a middle aspect, and we have the red nucleus here. And we basically have to target this STN, right? And for that, we use three coordinates, X, Y, and Z. After getting the MRI, this MRI is loaded on a software, and that software helps to target that area using these three coordinates. And after that, we get two tracks through which we have to go inside and put the lead into the brain of the patient. And for that, what we need to apply a frame. Actually, this frame is applied to basically get the three coordinates, x, y, and z coordinates, which helps us to go through the right track and reach the target. And after that, with this frame, actually, we do a CT scan. And this CT with the frame is fused with the pre-op MRI, and then we go and then we finalize the target and then go to the surgery. And basically, the surgery is done in two stages, as Dr. Nina pointed out. This is done in two stages. The first stage where the lead is placed inside the brain, and second stage is where the IPG or the internal pulse generator or the neurostimulator or pacemaker, whatever we call it, is placed on the chest. But actually, Dr. Nina told that usually we do it in 1 week apart, but that is optional actually. If you look at Western literature, especially US literature, you will see that these are done in 2 days. Actually, why? Because basically this is in US they do this because of the insurance purposes. They want to bill the patient 2 times, and that is why they do it in 2 phases. But in most part of the world, in 90% of the centers, both these stages are done on the same day. In the first, for example, in the forenoon, by noon, actually the first stage will be over, and the second stage, we continue with the second stage on the same day itself, and we finish off the whole process on a single day itself. This is what happens in most part of the world, including Canada or Toronto, where I did my fellowship, as well as in India. We do the same procedure. So anyhow, the first stage is done under local anesthesia. Why? Because we want the patient to be awake during the first stage. Why? Because there are testings involved. These testings will help us to place the lead at the correct spot, or the fine tuning of the final target. I will explain to you why this is so. Because there are two things which we do inside the theater. This is the role of the movement disorder specialist on the day of surgery inside the theater. Basically, surgeon do the implantation, but we do the testing and we do the electrophysiology. So the first part is intraoperative neurophysiology. Actually, we do the recording. Dr. Sachin talked about the beta band, the abnormal activity which we get in patients with the Parkinson's disease. This can be recorded using electrodes, and this is called a microelectrode recording. And the goal of this microelectrode recording is to define neurophysiological target. Why? Because anatomical targeting is through MRI, right, or scan, whereas physiological target we have to do through neurophysiology only. So, I'm sorry. And if you look at this, is the beta band activity, which for one of my patients is we recorded inside the theater when we are doing the DBS. You can see that there are 3 channels. We are using a 3-channel recording here. All the 3 channels are basically recording from the subthalamic nucleus, and we are seeing the beta band activity in this video. And then coming to then second thing which we do inside the theater is intraoperative testing. Dr. Nina mentioned about this, right? When we after the neurophysiological recording, we test the patient. We test the patient for 2 things. We give a test current through the same MER wires, and this is called a microstimulation. We are testing for 2 things. One is benefit. We can see the benefit of the stimulation there itself. For example, we can see the tremor coming down. We can see the rigidity coming down, and we can see the bradykinase improving on the operating table itself. And then also we test for side effects. Side effects, like for example, there can be a speech problem if there is a pyramidal tract stimulation. If there is a posterior place lead which is stimulating the sensory tracts, there can be paresthesias involved. People can have diplopia if it is stimulating the third nuclei, and people can have gaze problems and things like that. So this has to be looked at. And after taking all these available data into consideration, starting from the anatomical targeting itself, going to the physiological targeting, and then after the testing, looking at the benefit as well as a side effect, we finally decide the final position of lead placement. And the lead position is again verified with the fluoroscopy guidance inside the theater with the CM. And this is how we basically do the final lead placement of the DBS. Once this final lead placement is done, we do the second is on the same day itself, where tunneling of extension wires and IPG are done, and this is under general anesthesia. And the IPG is internalized, placed on the chest wall under general anesthesia. So this shows in nutshell what we are doing. We do an MRI, then we do the targeting, then we do frame mounting, then we take them to the theater, start the surgery, then we listen to the neurons through neurophysiology, and we finally implant the system into the body of the patient. And this is the post-op MRI of the patient. You can, I don't know whether you can appreciate 2 small dots here on both sides of the brain. And this is basically the tip of the electrode when after doing a DBS surgery. And this is showing the electrode or the lead which is placed and on both sides of the brain. And this is here we can see the 4 contacts on both sides of the brain. So then this is another diagram. This you're using a technology called a Sure Tune, a software called a Sure Tune. And this is the image of one of my patients who underwent ST and DBS last week in my hospital. And you can see that on both, this green area is the ST, and then you can see that the lead which has been placed in the ST. Doctor and Sachin sir talked about the sona inserter stimulation. The uppermost contact in such a DBS electrode placement is supposed to be in the sona inserter, which is good for some symptoms of Parkinson's disease. So this is a red nucleus on the red colored thing is a red nucleus, and this is a substantia nigra. This brown thing is a substantia nigra, and actually the last contact is usually in the substantia nigra in my patients. So and then after this, we send the patient home. They go home. They come back after 2 weeks for suture removal and things like that. And then we usually wait for 6 to 8 weeks for programming. This is basically a controversial area. Some people do early programming, but it is always best to do late programming. Why? I will tell you. Because after surgery, there will be some changes in the brain, right, including the edema, post-operative edema, the post-operative inflammatory changes, and all surrounding the leads and things like that. So for them, this is called the lesional effect, and this lesional effect actually produces some changes in the symptomatology of the patient itself. One point. Second point is that this lesional effect will actually interfere with the impedance of the programming when we do an early programming. Because of these reasons, it is always best to do late programming, and this was our practice in Toronto, and I follow the same practice and usually start programming at least after 6 weeks of the DBS. So they go home and they come back after 6 weeks in a medication off state. They come without taking medications to our clinic to do the programming. This is the physician programmer which we use, and the patient will get a small programmer, a remote like thing for say, minor adjustment of the current and all, which they themselves can do. And coming to programming, I didn't want to go into the details, but since most of the speakers about before me touched upon these things, I thought I will talk about a little bit about programming. But even if you don't understand much, don't bother. Basically, when we have to program, when we have to create a circuit, we need an anode and a cathode, right? And in most of the patients in the DBS, we use the case as the positive or the anode, the case as the positive, and one among the electrodes. There are 4 electrodes on both sides of the brain, right? And one among these electrodes, one among these contacts, there are 4 contacts on each side of the brain, and each lead there are 4 contacts which are numbered, and one among these contacts can be chosen as the cathode. So, and this is called a monopolar stimulation. But there is something called a bipolar stimulation. Bipolar stimulation, case doesn't come to play. Actually, one among the contact itself becomes the anode, and the other contact becomes the cathode. Why? Because this is basically done when there are side effects with the monopolar stimulation, or then when we feel that effects are not that good with monopolar stimulation, then we can try this. But usually it is used when there are side effects with the monopolar stimulation. So this is regarding electrode polarity. And then we use 3 parameters of programming. Dr. Nina touched upon this: amplitude, pulse width, and frequency. Amplitude is basically the amplitude of the current which we give, and it usually ranges between 1 to 4 volt, and I'll forget about it, but this is the amplitude of the current which we are using. And coming to pulse width is the width of each pulse of the stimulation which we are giving, and it is given in microseconds. So the pulse width ranges from 60 to 450, but standard pulse width we always start to 60 and then adjust depending upon the response of the patient. And the third parameter is frequency. Frequency is the number of stimulations per second, number of stimulations that we give each second. So the usual frequency, standard frequency, we start with 130, but we can increase frequency or we can decrease frequency depending upon the response of the patient and depending upon the symptom profile of the patient. I will not go into the details because that is not within the scope of this discussion. Anyhow, what to expect after programming? Basically, the most important thing is that we expect changes in the motor symptoms of patients with Parkinson's disease, especially tremor, rigidity, bradykinesia responds very well. And in different studies, the range of improvement is said to be around 50 to 70% with of symptom improvement with the deep brain stimulation alone. This is apart from what is produced by medications, right? And what are the benefits of DBS as we saw the symptoms are reduced with the DBS. By DBS itself, we get 50 to 70% improvement. Then because there is an improvement with the DBS, we can always reduce medications. Most of these patients, we can reduce medications, but this is not a hard and fast rule. This is not for all patients, but most of the patients, we can reduce medications. And in those patients in whom we can reduce medications, there is a reduction in the side effects of medications, especially the levodopa-induced dyskinesia, which I was talking about earlier, and I showed a video on dyskinesia, right? And such dyskinesias can be improved after DBS. Why? Because we can reduce medications as well, and there will be less motor fluctuations. We talked about the second stage of a PD called motor fluctuations, right? When the patient has got benefit of medication, when it is called on. When the patient has got no benefit of medication, it is called off. For example, this is depicted in this picture. For example, this patient takes medications 4 times. Patient has got 4 on phases, and the patient has got 4 off phases, right? During off phase, there is no medication effect, and then the patient has got all the symptoms coming back. But DBS is a battery which works 24 hours. Even when the patient is sleeping, DBS works. So during the off stage also, DBS benefit is there. So instead of the patient fluctuating like this, the patient have a more controlled fluctuation, and during the off stage also, when the medication is not working, because of the DBS effect, the patient has got reduction of symptoms. There they can do their activities of daily living, and their quality of life improves. This is probably the single most important reason why we are doing DBS, to get rid of the fluctuations. And coming to complications, DBS, again, any procedure is not without any complications. Dr. Neena talked about this. Actually, there are 2 important complications which we should be bothered about. One is bleeding. The chance of bleeding is around 1 to 2%, but the chance of severe bleeding or a large bleeding enough to produce weakness is 1 in 250 only. So this is so we should not be thinking that this is the chance of bleeding is very high or this is going to harm the patient. No, actually that is rare. Actually, the symptomatic bleeding is rare, and this is one CT scan of a patient. I think you can appreciate this white area here. Blood looks like blood and bone looks at white in CT, and this area is a bleed after a DBS, and you can see the bleed around the DBS lead. And the second complication, again, infection. The 3% chance of postoperative infection is there, and this again, the lifetime risk is around 7%. Again, this is an infected area. The patient has meningitis following the DBS lead implantation, and this CT shows this is dark area is the edema surrounding that. And if infection occurs, we have to give antibiotics. Some patient responds well and good. If the patient doesn't respond, then we may have to take out the device. We have to explant it, and then after around 3 months or so, once the infection is controlled, we can again go to a DBS. Okay, then coming to side effects, and coming to the last few slides of my presentation, coming to side effects, again, DBS is not something without side effects, because the stimulation may go into the adjacent neural structures and produce unwanted effects. That is what we call it side effects, right? In the case of STN, motor side effects can occur when there is a pyramidal stimulation like dysarthria, muscle spasms can occur. When there's a visual stimulation, diplopia can occur because of the third nerve nuclear involvement stimulation. And sensory stimulation when in a posterior placed lead can produce paresthesias. So this diagram shows a well-placed lead in an STN, and this patient is not expected to produce any side effects. Whereas when there's a posteriorly placed lead that can stimulate the sensory structures and produce paresthesias. When there's a medially placed lead, it can stimulate the third nucleus, and this can produce diplopia. When there's a laterally placed lead, where most important side effect actually in laterally the cerebral tract comes into picture. So this is a disabling side effect actually if it occurs, and it can produce muscle spasms and dysarthria, gaze deviation, things like that. So then coming to GPA, side effects are lesser when compared to STN, but still there again motor same thing. Visual force winds can occur. Why? Because this is, I will show you through a picture. This is a well-placed lead in the GP on both sides. This patient is not expected to produce any side effects. You can see the vitamin GP and the GPI here. The optic tract is here. But when there is a medially placed lead in GPI, the pyramidal tract comes medially. So when there is a medially placed lead, that can produce pyramidal tract side effects like dysarthria and muscle contraction, unwanted muscle contractions. And when there is a deeply placed lead, if the last contact is inside the optic tract, then stimulation of that contact itself alone can produce a visual force winds. But I should tell you that don't get carried away by seeing these side effects. Basically, most of these side effects can be addressed by programming, because we have 4 contacts. Even if it is one contact which is working well, still DBS works for the patient. And again, when we talk about a neurosurgical procedure, a surgical procedure with more than 95% success rate or less than 5% complication rate, it is a very good result, or a very good surgery, or a very safe surgery. So don't get carried away by these slides and think that DBS is something which produces side effects or complications. These are unlikely and rare side effects or complications. Most of this can be addressed by different ways. And I will end with a single patient's video. And this is the video of a patient, one among my patient whom I did DBS. Look at the restaurant of this patient. He is in off state actually. Now he's trying to walk. He can't walk actually. When he tries to walk forward, he tends to fall. This is the off state when the medication is not working, when the disease symptoms are all in the form. But whereas when it comes to on state, this is the patient has taken his medication. You can see that his tremor frequency, severity has come down. He has some improvement in tremor. But in the on state, when the medication is working, he developed this bizarre dyskinesia involving the right lower limb. So basically, this patient, while on medication, because of this dyskinesia, he can move, he can walk. Most of the time, he was bedridden without being able to do any activities, and he was in his early 40s when he came to me. And we explained the importance of DBS to the patient, and they accepted the treatment. And actually, we took him up this patient for DBS. This was my first patient at Lourdes Hospital, where I did my around 30 DBS there, and this was my first patient there. And look at this bizarre dyskinesia on the right lower limb alone. He had a disease onset on the right side of the body. And this is 3 years after doing DBS. And when he came to my clinic for a review, this is how he is after 3 years of DBS. Look at the improvement. His tremors are no longer disabling. He can walk. His dyskinesia is not at all there. All his dyskinesia is gone away. And I did actually GPA DBS for him because he had a predominant dyskinesia. But I will not go into the details of that regarding the indications of GPA versus STM, but that's not required, I believe. So basically, DBS can produce such good results in carefully selected group of patients. So thank you all for your attention. But I don't know, my dear little ones and my junior most colleagues who has entered the profession, I don't know whether I did justice to you by doing this presentation and taking your time. But anyhow, thanks a lot for your time and your attention. Thank you. Bye.
I think thanks to both the speakers for the excellent presentation. Can I have a few comments, madam?
Sure. Please go on.
Yeah, Dr. Sachin, a very interesting presentation. He talked about the different pathways involved in Parkinsonism, the role of the nigrosome, which is something new, the neuromodulation and the neurochemical effects of DBS, including high frequency oscillations and the role of adenosine. So one point which I wanted to highlight is there has been increasing interest in the role of the pedunculopontine nucleus or the PPD nucleus in the pathogenesis of Parkinson's. So for the benefit of students, can you tell us a little bit more about the role of pedunculopontine nucleus in these movement disorders?
Sreeram, you want to speak about it? I am not that well versed into that.
Again, I am not also
Maybe
that
Sreeram,
basically the pedunculopontine nucleus has got a role in gait and balance. And basically, the people have tried pedunculopontine nucleus stimulation in those patients who have got predominant axial symptoms. Actually, even people have tried PPN stimulation patients with the PSP actually because predominantly they have falls and axial symptoms, right? But actually, results has not been that promising or not that good actually. This PPN stimulation actually started the interest in PPN stimulation actually started at least around 2 decades back. In the early 2000s, when people started doing PPN, as I told, in patients with PSP in some patients, and also in patients with PD who has got predominant axial symptoms. But some patients have shown positive results. But when we talk to experts, when we talk to experts, and when we go to conferences and talk about this, the impression that we get is that the improvement is not as robust. So many people are not very interested in suggesting this treatment because of the risk of taking them through a neurosurgical procedure, and if the benefit is too little, then people are not very keen on that. But there are certain people who do combined stimulation. Anyhow, when the patient goes for an STM stimulation or GPA stimulation, some people do combined stimulation where they stimulate the PPN also along with other stimulation to address the axial symptoms. But the results are not as robust as that of STM or GPA. That is why people are a bit reluctant in pushing it forward in a big way.
And the other problem which we face while referral is the cost factor.
Yeah.
So most of the deep brain stimulations cost around, I think, somewhere between 8 to 12 lakhs. I think. Is there anything we can do for the poor pay, because that's a little out of the range for most of our patients?
Yeah, I agree. And basically, I didn't talk about the cost factor and all because there are social things going on, the economic factors and all. Basically, to be honest with you, the cost of DBs is increasing over years. Why? Because these are multinational companies, right? They will tell that the rupee has devalued, the dollar has increased, and things like that, and they will revise the cost every year or every 2 years or so. At present, actually, when we have to do a DBS, we need actually at least minimum 12 lakh rupees. Actually, when I started doing DBS, we are doing it for 9.5 and 9.5, close to 10 and all. But gone are those days. Now we need at least 12 because the cost has gone high, and every time they bring a new technology, naturally they increase the cost. So I agree that cost is a big factor, especially in our part of the world. When I was in Toronto, we never talked about cost during our counseling. Why? Because all are insured. Patients don't have to bother about that. We don't have to bother about it. We just have to tell the pros and cons of surgery and take them for surgery. But here we spend a lot of time talking about cost, and most of the insurance companies don't cover. So it's definitely a factor. And minimum we need around 12 to do a non-rechargeable battery itself.
Is there any role for early referral? Most of the conventional thing is a referral after 4 years or at the onset of dyskinesia. Are there any? Is there any scope for referrals little early in the disease? Is it of any benefit?
Sir, Dr. Krishnan, if you ask me, the early referral, thing is that we can tune them. We can actually counsel them early, and then we can tune them, and we can tell them what to expect in the years to come, and then we can tell that these options are there, so you get better prepared, including economically. And actually, many neurologists, what they do is when a patient comes with the minimal symptoms itself, they ask them to take an insurance with a good coverage, more than 20-25 lakhs and all, so that by the time they progresses to develop the disease, then they may have some coverage through their insurance and then get DBS. Early reference regarding counseling and regarding priming them, tuning them for and getting them adapted for such a treatment in a few years down the line, that helps.
Basic problem, like Dr. Krishnan, is that it is this referral is like you are a neurologist who is actually talking about referral. I don't see any neurologist talking about referral these days, or any physician for that matter. Nobody talks about referral to a specialist. For example, this is, as you know, this is more prevalent problem in case of epilepsy, because I deal primarily with epilepsy. And I see refractory patient, forget about 2 years, 4 years, at least 20 years later, if a patient is having 5 seizures per day at least, please refer these patients. That is what I tell people. And the cost is like 3 or 4 lakhs, not like 12 lakhs. But this thing is that this tendency, like we to have the best for the patient, that attitude as a clinician, as a physician. For example, Sreeram is also working with us in Mathews Hospital, Kozhikode, and he also does. We also have the DBS program there. We are able to get it done for about 12 lakhs. So the thing is that to have a person in the team and then develop a program specifically for that mindset should be there at least. Obviously we know that the cost is a prohibiting factor, but at least we are thinking in terms of providing the best treatment options to our patients as whatever is at whatever level it is possible. Then, like, how to change the cost factor. For example, I am also not able to do stereo EEGs here because the stereo EEG cost will go more than 10 lakhs for epilepsy. So how to change the cost factor is that, ultimately we should have, the programs like just tuberculosis program is there, like that. We should move, bodies, political bodies, governments and all to take legislation in this direction, or at least the government setups also should also start coming up with these options. And until then, like you said, it will not be uniformly available to all groups of patients. But at least our part as neurologists, I've seen somebody talking about referral. I'm really happy.
The first questions to me actually.
I refer a few patients to Sreeram, so that's why. Any, madam, you want to take some questions from outside, from the audience, from the students?
Yes, now it's time for the Q&A session. And first of all, there'll be a formal vote of thanks. But of course, I think I definitely need to thank both our speakers who have been very clearly explaining, they have come down from their level to a first year level. And as a classmate, I know Dr. Sachin has got a lot of techniques up his sleeve, how to learn difficult things very easily, and he's shared some of his techniques here. Something about sit and pet. Hmm? I'm sure the first years can utilize all that. And learning these basics is a very important aspect, because once you learn these basics, you are thorough about something. But now you know why you're learning all this. So when you hear a session on Parkinson's disease, when you hear a session on DBS, the students will definitely know why they should learn about basal ganglia. Why is it important to learn about their anatomy? Why is it important to learn about their physiological, functional aspects, their connections, and all that? So definitely, the reason for studying becomes more clearer. So I think on a personal level, I would definitely like to deeply thank both of you and Dr. Krishnan for helping mediate these sessions, smoothly. So we'll open the forum for Q&A now. So if you have any of the students on this meet or on the YouTube link have any doubts, please post them now.
Thank you, Anne and M.O.S.C team for selecting the topic and very good arrangement for the webinar. And I have one question to Sreeram. Whether you have seen any voice changes after surgery, changes in the voice coming back to the normal after surgery.
The question is regarding what happens to the voice in a patient with Parkinson's disease after DBS, right? The hyperphonia can improve after DBS, but DBS can also sometimes worsen speech. Especially STN DBS, it can worsen, it can affect the fluency of speech, and it can worsen speech as well. But when a person develops worsening of speech after STN DBS with the programming, we have got certain programming options to improve their speech, especially the bipolar stimulation, which I was talking about earlier. When we see speech worsening with the monopolar, we sometimes try bipolar stimulation and try to help their speech. So the speech may improve, but in a small group of patients, it can worsen as well after DBS. But as if a person's speech worsens, then we can help them with the programming. And again, if a person has got a very soft speech or a significant impairment of speech pre-DBS, we may sometimes we may even sometimes choose the patient for GPA DBS. But and as I told, in majority of the patients, and it improves with the programming. But some patients can have a worsening, which can be addressed with the programming options.
Thank you.
Shivani, are there any more queries from any of the participants? There's a query posted. There's a query posted. Why is it that we put the neurostimulator on the chest wall and not near the leads or scalp? That would just increase the complications of the surgery, since we have to channel the extension through the internal viscera.
Oh, great
The
question.
body.
This is regarding the logistic things. Actually, the thing is now, the battery is not that small. Actually, it's not that small to put inside the scalp. If and I would have liked to have to get a battery which is that small and which can do this job and which can be put inside the scalp, but unfortunately, it's not available. Even the smallest battery which is available itself is around 2 inches or so, in length and breadth, and the thickness of around half inch or so. And this has to be, and we need a larger area. If you ask me whether it should be put inside the chest itself or why can't you put it inside the abdomen, it's possible. But then you need even a longer extension, right? The shortest distance which we can traverse and put it in a fairly good place. Basically, they make a small pouch inside the chest or the pectoral muscle, and then they put this device. So basically, it's all regarding hardware issues, and we don't have a technology by which we can put a small chip-like thing inside the scalp and then close it and then stimulate the patient. Unfortunately, that's not available.
Yes, I got it. Thank you.
So there's one more doubt, sir. How are doctors able to link certain neurological disorders to specific brain centers and connections?
Okay,
Oh my God.
so that is probably that I mean, it all comes from that is where I have been talking to Anne also about this thing. Like, there's so many things that you can contribute to understanding. That is the of all these things. So actually, that mostly comes from neurophysiology, neuroscience as a branch. So if you look at European centers or if you see the centers which what was that center Strums or whatever where they got recently Nobel Prize. What happens is that there is excellent collaboration between the clinical groups and the basic science groups. Absolutely seamless coordination. So what happens is that the research goes at that level. So there is that is known as now what we call as a translational research and all. So from the bench to the from the clinic to the bench, so that from the lab it should reach the patient. So that pathway, so the understanding, the transfer of information goes bilateral. So in Parkinson's disease, if you say they have animal models, there are MPTP mouse and there are other mouse models. There are different kinds of models. Animal models is one way of using it. Second, all this we can also use stimulatory models. The DBS in animals also we can stimulate in front, basic science research. Then we can use computational models. We can use AI based or computational models, and then we can also, like I told you, where this happens mainly in centers where there is excellent coordination between the clinical and the basic science. So that is the model that we have to create in our country, in our part of the world. We should have a bilateral collaboration on the scientific front, and then we will be able to understand diseases better. And like I said, as I mentioned a few times, that will be the future, where you will understand the exact mechanisms. Now we are just having a crude understanding. We have shared with you only a very crude understanding of what we know. But then we have to know it much more precisely to make significant changes in our management approach. If we are going to understand diseases, their disease processes better, we will treat patients better.
Yeah, thank you. There's one more doubt, sir. Will this be done with patients with ICD or pacemaker?
Can you clarify that question?
Will this be done with patients with ICD? Jillian, can you just expand?
No, I understand. A patient who is already having an ICD or a pacemaker, a cardiac pacemaker, whether DBS can be done. The answer is yes, it can be done.
Thank you, sir.
Though I have not done any, in my experience, I have not done in any patient, but theoretically possible. It can be done. It's not a contraindication for DBS.
So it does not interfere with the vibrations or communications. That's
Usually it doesn't, because probably because the other one looks at the beta activity and the parameters which we are looking at in these two diseases are different. Probably that's the reason, but it can be done.
It's all a localized delivery. It's very stereotypically guided and very localized delivery. For example, the stimulation that is happening in the subthalamic nucleus is not even affecting the rest of the brain. Why would it affect the heart? So that is very localized.
Yes. And there's another doubt, sir. Can we use this effectively in individuals who are using other implants, like cochlear implant?
Cochlear implant. Can be done. It can be done. Having another implant is not a contraindication for DBS.
Mm-hmm.
Only thing is that the implant should be MRI compatible. We need an MRI before doing DBS. Only if the implant is not MRI compatible, then it may have a problem. Otherwise, it can be done.
Yeah. So I think many of the doubts have been clarified. Shivani, can you just check up if there are any more queries?
Ma'am, I think these are the only questions.
Okay. How about on the YouTube comment box? Are there any queries there?
No questions till now.
Okay. So I think it has been a good discussion. So we can move on to the vote of thanks. Shivani, please.
So lastly, I would like to invite Dr. Minolis Abraham, Associate Professor, Department of Physiology, for the vote of thanks.
Yes, as we come to the end of this webinar, on behalf of Department of Physiology, M.O.S.C Medical College, it's my proud privilege to propose a vote of thanks. First, let me thank Almighty God for all His blessings and the grace on this occasion. My sincere gratitude and respect for our distinguished guest speakers, Dr. Sachin and Dr. Sreeram, for sparing their valuable time for us and enlightening us with their commendable talk on the topic. Thank you for clearing up the students' concepts and enhancing our understanding. I also extend my sincere gratitude to our respected Dean, Dr. Divakar Sir, who supports us in all our activities. I also express sincere gratitude to Dr. Krishnan Sir for moderating the sessions and providing valuable support in their webinar session. I also extend my warm regards to Dr. Nina Mathews for briefing about the deep brain stimulation, which is quite informative. Last but not the least, I thank all our students and all the distinguished invitees present here for accepting our invitation. Once again, I thank you for all your attention. Thank you.
Thanks, Sreeram and Dr. Sachin. Thanks for
Dr. Krishnan, nice meeting you through this webinar.
yeah, nice meeting you. So, thank you, Dr. Anne, again for the opportunity.
Thank you. Thanks to everybody. Thanks to the speakers. Thanks to the, moderator, for everybody, for the students, for the participants. It has been a very interactive session. It has been a live and enlightening session. And on behalf of all of us, we sincerely appreciate your presence here. Thanks a lot.
Thank
So
you.
we can
Bye,
wind up
sir.
our session.
Bye.
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 Thank
Bye.
you.
See you.
Thank you, ma'am.